Okay, so last time we were talking about the intracranial circulation, cerebrospinal fluid, and Moody came up after class and said, well, maybe we should talk a little bit about infection. And so there are actually two types of hydrocephalus. There's a communicating and a non-communicating. And so we talked the last time about the non-communicating. That's where you have a blockage typically at the aqueduct facilities. Okay, but there is another kind of hydrocephalus that you can get, which is a communicating hydrocephalus, and that's where the fluid completely communicates from the ventricles through all the different foramina. But there's actually been a blockage up at the arachnoid granulations. Okay, and that typically occurs because of various kinds of infections that you can get in the intracranial space. Now, specifically the question I was asked, I think, was about an amoebic abscess. So you can get all kinds of infections. I've seen people that had worms that have gone to their brain and created an abscess. Amoeba is something you can get if you go swimming in Lake Austin. Typically, it kind of gets into the intracranial space through your nose. So those of you who like to go waterboarding or skiing, that's not an uncommon way you can get an amoebic abscess. Another way you can get an infection is with meningitis. That I think y'all probably had a vaccination for meningitis. Is that right? Or, so, the meningococcal meningitis is a type of meningitis that occurs when people are like in dormitories that are kind of close together. There's viral and bacterial kinds of meningitis. But the bottom line is that you basically get pus that's in basically where the cerebrospinal fluid should be. And the way you diagnose it is by doing a spinal tap. If you do a spinal tap, if it's a bacterial meningitis, you can actually culture the bacteria and specifically aim your treatment at particularly whatever it was that you cultured on that LP that you did. A lot of times it's viral, and we don't really have a good way to get the diagnosis real quick, but we can do PCR testing, and we can figure out kind of what the virus is, again, by looking at a specimen from the lumbar puncture. The bottom line, though, is that irregardless, you have white blood cells. Ordinarily, the cerebrospinal fluid is a clear acellular fluid, and when you get meningitis, or if you get a cerebral abscess, for example, if you get the amoebic abscess that I was asked the question about, you get pus in the cerebrospinal fluid, and that blocks the arachnoid granulations. And so the end result is that you get an elevation of intracranial pressure. Now, with the meningitis, there's some other bad things that happen. And one of the really bad things that happens with meningitis is that you can lose your hearing. And so it's not uncommon that typically the kind of story is, a young kid, 4 or 5 years old, perfectly normal, gets meningitis, and the meningitis wipes out the hair cells in the inner ear, and all of a sudden you become profoundly deaf. And so meningitis is a really bad thing. Now, the kind of the cardinal symptoms of meningitis, besides the fact you have a bad headache and you don't feel good, usually there's fever, and you get a really stiff neck. And so you also get these other signs that are on this slide, Koenig's sign and Brzezinski's sign, and basically you just get rigid. You can actually take somebody and just lift their head, and they're just like a stiff board. They just kind of lift up in one piece. So that's kind of diagnostic for meningitis. And obviously, the treatment is specifically, if it's bacterial, you give antibiotics. If it's viral, you get supportive therapy. And if it's an abscess, like an amoebic abscess, really, really, really hard to treat. There's just not a lot of good antibiotics for that. And so a lot of people that get that die. Any questions about infections? Okay, so kind of the next thing that I wanted to kind of talk about here, I want to kind of begin a discussion about the circulation. So I think I've convinced you maybe that circulation in the brain is very important. We have about 2% of our body weight in the brain, but 20% of the cardiac output goes to nourish the brain. We only have a 3-minute reserve. And so the way that these blood vessels are all kind of connected together is really important. And I want to kind of bring your attention here real quick to this area, kind of this area right here, because that area is a very, very busy area. It has a lot of blood vessels, it has a lot of veins, has a pituitary gland, has a whole bunch of cranial nerves, and that's an area that that actually can get involved in a lot of different diseases. And so I just want to, kind of focus your attention kind of on that particular part of the brain. Now, blood gets into the brain via two possible ways. It comes in the posterior circulation through the two vertebral arteries, which join together to form the basilar artery. That then, as we'll see in a minute, divides to form the posterior cerebral arteries and becomes a part of the circle of Willis. The other way that the blood gets into the head is through the carotid arteries. And so we have an external carotid. I want everybody just to feel the pulse. You can feel that on your neck. That's your common carotid. The carotid bifurcates right up close to the jaw. And actually, so the common carotid becomes internal and external carotid. The external goes to the muscles of your face. The internal carotid is going to go up the carotid canal, come through foramen lacerum, and then enter the intracranial space. And the internal carotid is going to provide the circulation for the anterior 2/3 of the brain. And so you can kind of see this. We have here the internal, I'll trace it out for you. We have the internal carotid here, which comes up, and something very strange happens here. The internal carotid artery, the artery actually pierces a vein. The vein is called the cavernous sinus. Okay? I don't know any other place in the body where an artery, a big artery, just goes right through a vein. So you have the internal carotid going through the cavernous sinus, and then it goes up and joins into the circle of Willis, which we'll see in just a minute. Where I drew that circle here, I also want to draw your attention to the fact that the ophthalmic artery, which is this artery right here, which goes to the eye, is the first branch of the internal carotid once it's in the intracranial space. And so the ophthalmic artery is particularly vulnerable to embolic events. And so if I have a plaque in my carotid artery, the very, very first place that an emboli, a blood clot, can travel in my head, the very first place it can go is to my eye via the internal carotid ophthalmic artery connection there. And so there is a syndrome which is called amaurosis. Jacks. Okay, which is a important syndrome for you to learn, and that is a patient a lot of times before having a stroke will present with transient loss of vision. So the symptoms are Mrs. Smith comes in to the eye doctor and says, I'm seeing good, vision is 20/20, I'm fine. But the other week, I was driving down Mopac, and the vision in my right eye, it just went out for about 30 seconds. But it came back, so I didn't really think much about it. Okay? Well, that raises a red flag. Okay? So, if the vision just totally goes out in one eye, there's only one thing, and it comes back in 30 seconds, there's only one thing that can cause that, and that is if you've interrupted the blood flow. And so that syndrome is called amaurosis. And if you have somebody that has that kind of a presenting symptom, you're obligated to do a very thorough workup of the circulation. Particularly, you want to do a carotid Doppler. You want to look for a plaque in the carotid artery, typically at the bifurcation. Or it could be that maybe Mrs. Smith had an arrhythmia. I mean, that could come from the heart too. So you want to be sure you check the carotid, you want to check the heart just to see if you can find out where that, you know there was an embolus, you know that for sure, okay, but you want to find out then where that embolus, came from. Why would you want to know that? Haley? Why would you want to know that?
Well, I mean, you'd want to know where there's plaque building up so where you can take it off so you can predict where it will go in the future.
Well, you really wouldn't want it to happen again, would you? Because the next time that might just go to the brain, right? If it goes to the brain, you have a stroke, okay? So this is like a warning signal, kind of like a harbinger of a stroke, okay? So basically this is something that tells you that you're going to have to do a very, very thorough, medical workup to try to find out where emboli are coming so that hopefully you can treat the underlying carotid disease by doing an endarterectomy or by treating the arrhythmia in the heart, or maybe they've got a bad heart valve. You want to treat that before they get a stroke. Okay? So that's called amaurosis. Okay? Any questions about that? Yes?
So we have a 3-minute window with the brain for blood loss. Is there a similar window for blood loss to the eye?
Yes, absolutely. So one of the things I'm going to convince you in this class is that the eye is actually a part of the brain. It just happens to be kind of where you can see it. Okay? Everything that's true about the brain is absolutely true about the retina. You interrupt the blood supply to the retina for 3 minutes, it dies too. Okay? Yeah, good question. So the brain, so as an ophthalmologist, I think of the brain as being a backward extension of the eye, okay? A neurologist thinks of the eye as being a forward extension of the brain. So it just depends on your perspective. But they're one and the same. Okay, so this diagram is also good because it kind of shows, where the posterior circulation. So this is the vertebral arteries. So these are the vertebral arteries here. They kind of come up and join to form the basilar artery, which comes up through the foramen magnum. And then we've got all this business that's going on that's kind of complicated, where the carotid's coming up and it's going through the cavernous sinus. And so we're going to look at that area here in a little bit more detail. Before I do that, though, I want to mention one more important syndrome which you need to know, and that's called a carotid cavernous sinus fistula. Now, because of that really kind of a unique anatomy where the artery goes through a vein, this right here, the carotid, the internal carotid is going through the cavernous sinus. Because of that anatomy, okay, if you get hit on the head, one of the things that can happen is you can tear the artery as it goes into the vein. There are actually some little thin little places where it actually penetrates into the vein. And when that happens, you get a carotid cavernous sinus fistula. Carotid cavernous sinus fistula. And what happens here is you get arterial blood that's then going directly into a vein. And when that happens, you arterialize the vein. So that vein is supposed to have low pressure, but all of a sudden now you've got artery that's passing high pressure blood now into the vein. And guess what happens? The very first thing that happens is the ophthalmic vein, which is the closest vein there, the ophthalmic vein dilates, and then all of that arterial blood goes to your eye. And that produces the brightest red, bulging, pulsating eye that you have ever seen. And so the patient comes into the clinic and says, Doc, I don't know, a week ago I was out working outside and I just accidentally hit my head against a low-hanging tree limb. I didn't think much of it until about a day or two ago. My eye started turning red and I think I have pink eye. And you look at them and you say, no way, this isn't conjunctivitis. You've got, and you can take your stethoscope and put it on the eye and you can actually hear the blood flow. It goes swish, 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 swish. You can hear the fistula, okay? And so this kind of patient doesn't need a an antibiotic, this kind of a patient needs a neurosurgical intervention in order to treat the cavernous sinus carotid fistula. And so, how do you think you might fix that? As biomedical engineers, how would you approach this problem? This is in a terrible, terrible place to get to. I mean, it's down, close to the pituitary. I just showed you. It's kind of at the center of where the brainstem is. I mean, horrible neurosurgical approach.
Can you bypass it?
Bypass it? That actually is one possibility, just to make a bypass. But somehow or another, you're going to have to ablate the fistula too, right? Otherwise, you can get backflow. So how are you going to ablate the fistula? Well, we like to do things now through minimally invasive surgery. So one of the things we could do is through the femoral artery or through the carotid artery, pass a little catheter, and we can put either a little coil of wire that will coagulate and just close the hole, or we might put a little balloon there, just enough to maybe seal that off to where you could get a blood clot. Okay? And so, that's kind of the preferred way to, so it's called embolization of the, basically you want to create an embolization of that, carotid cavernous sinus fistula. Any questions? Okay, so get back to the circulation now. So we have two major circulations. We have the posterior circulation, the vertebral basilar, and the anterior circulation from the internal carotid. Now the internal carotid provides the blood supply to the anterior, basically 2/3 or 3/4 of the brain. And that posterior circulation, which is shown in green here, goes to the occipital cortex and to the lower part of the temporal lobe. And so how this all happens is really kind of cool here. And this happens in a structure here that is evolved to give us a incredible survival advantage, and this is called the circle of Willis. Okay, and what the circle of Willis does is that if you block any of the 4 big blood vessels, now remember we have the 2 vertebrals and we have the 2 internal carotids, so we have 4 big blood vessels that are going up to nourish our brain. And because of the circle of Willis, you can knock off 3 of the 4. As long as you have 1, you can actually perfuse the whole brain. Okay, so if the arterial sclerosis or hardening of the arteries or whatever occurs very slowly over a long period of time, this circle of Willis will dilate, and it will actually provide the blood flow to the whole brain from just 1 blood vessel. Okay, 1 out of the 4. Pretty redundant. That's a cool engineering, kind of a principle. When we design things, we design redundancy in the system, and this is a redundancy in the system. And so I'm going to go over with you what the circle of Willis is. And so here we have, let me get a different color here. You can see it. Okay, so we got the blood that's coming up the 2 vertebrals here. Okay, so here's number 1, here's number 2, and then we got number 3 over here, the 2 carotids, 3 and 4 over here. That's still pretty hard to see. Let's see if I can find a different color. Maybe try one of them. Try a blue. But anyway, so here we come up. This is the basilar artery. So the 2 vertebrals join. They form the basilar. Okay, the basilar splits into the 2 posterior cerebrals. So those are the 2 posterior cerebral arteries. This little artery right here is called the posterior communicating. The posterior communicating goes anteriorly. It joins the internal carotid. And then the internal carotid divides into the anterior and to the middle cerebral arteries. And there's another little artery here called the anterior communicating, which you can see, I think, on this diagram here. So this is the anterior communicating, and these are the two posterior communicating arteries. Okay, and so it basically forms a circle. The circle goes from the posterior cerebral, posterior communicating, internal carotid, middle, anterior communicating, internal carotid, posterior communicating, posterior cerebral. That's called the circle of Willis. Okay, and that provides the redundancy. Why is this interesting or important? Yes.
I vaguely remember talking to someone that a large population of either the U.S. or just worldwide population actually has an incomplete circle of Willis.
They do. It's not 100%. Okay, and actually, if you're healthy, it's almost atretic. Almost nothing goes through the posterior communicatings or anterior communicating as long as you're healthy. Okay, it's only when you get sick, or only when one of the blood vessels actually gets blocked, that you begin to dilate and actually have a lot of blood that goes through these smaller blood vessels. Now, the other problem is that these blood vessels are relatively small and they don't have as much muscular wall to them as the other blood vessels, the vertebrals and the posterior cerebral artery, internal carotid. And so these are fairly weak blood vessels that can dilate. That's actually what they're supposed to do if you have a blockage. Okay, but because of that, it also can cause some real bad problems, as we're going to see in just a minute. It can cause an aneurysm to form. Okay, have y'all ever heard of an aneurysm? Do you know what an aneurysm is? Jesse?
It's where the blood like builds up and the thing.
Kind of makes a little sac that kind of bulges out because it's a very thin-walled blood vessel. So it's a good thing, but it's also a bad thing. Okay, and that's a downside to the problem. So let's kind of go through another interesting picture here. Now, anatomically, and actually on some real brains, I'll show you. You can actually see it. It's actually even easier to see on a real brain. But again, let me kind of point out here. You have the vertebrals, the basilar. Okay, the basilar goes to the two posterior cerebral. This is called the posterior cerebellar artery. That's not in the circle of Willis, but here is the posterior communicating. Here's the internal carotid. Here's the anterior cerebral. Here's the anterior communicating here, and then that goes back and forms that full circle. Now, again, it's very busy because involved in with this is the third cranial nerve, the second cranial nerve, pituitary gland, and these are all really, really close to this circle. And you can see if there's an aneurysm, it's going to affect some of those structures, and we'll see how that works out here in just a minute. But you can also see this is the middle cerebral artery, and the middle cerebral artery goes out here to what's called the trigone of the middle cerebral artery. And it turns out that this is where you actually get a right angle turn. Anywhere you get a right angle turn, you get turbulence, and because of that, that's actually a very favorite place for a blood clot to stick. And so the most common form of ischemic stroke is an emboli which blocks in the trigone of the middle cerebral artery. And that gives you a kind of a classic set of symptoms that we can look at in just a second. But you can see how these things are related to some of the other structures. I'll point out to you that this nerve right here is the third nerve, and it gets involved in a bunch of the syndromes too. So we've got, in this vicinity, we have the pituitary, the optic nerve, we have the oculomotor nerve, and all these things are in the same kind of regional vicinity where if you get an aneurysm, it's going to affect that. So anyway, that's called the circle of Willis, and the way that blood kind of gets into the brain. And let me also, I should have pointed out here in just a second that the blood flow, most of the blood flow actually goes to the surface. So that if you look at where the vast majority of the volume of flow is, it's on the surface. Why is it on the surface? Because the cells are on the surface. So your gray matter to your brain is on the surface. The white matter is on the inside, with the exception that you have these deep nuclei that are associated with the diencephalon. And so the nuclei that are associated with the older part of your brain. So again, most of the blood is going to this part which is the gray matter, the cells that are on the surface. But we have this area right here, which is the thalamus, the caudate, the globose pallidus, and the putamen. We're going to look at this in more detail in just a minute. But all collectively, this is called the diencephalon. And we have these little tiny blood vessels that come off here. These little blood vessels are called the lenticulostriate blood vessels. And so these are also vulnerable because they're really small blood vessels, but they're perfused with a very high pressure. And so you have the middle cerebral artery here. It's coming out to the trigone here. And you've got a situation here where if you're hypertensive, if your blood pressure is too high, this is a really bad scenario because you're going to possibly have a hemorrhage. And so most intracerebral hemorrhages that occur within the brain substance occur in the basal ganglia because of these lenticulostriate and medial striate arteries. And again, it's not from a biomedical engineering standpoint, it's very understandable because you have a very small blood vessel which is perfused at a very high pressure, and that's just a weak point in the blood circulation of the brain. And so it turns out that we can have different kinds of strokes. The more classic kind of stroke is where we have an embolus that comes from the carotid or from the heart, and it blocks one of the blood vessels in the brain. And your symptoms are going to depend upon where the clot lodges. It's going to depend upon which part of the brain gets infarcted. And so, again, the most common place that these stick is in the trigone of the middle cerebral artery, and that produces a classic set of symptoms, which are sudden onset of paresthesias, which are tingling in your hands. Typically, it's tingling in hands and leg on one side, associated with weak motor function. So you lose feeling, you become paresthetic, and you become weak, you lose motor on one side. Now, if you're right-handed and this is all going on in your left brain, then you're also going to have some affliction with your speech. And so typically, the presentation is a person who maybe is hypertensive, hypercholesterolemic, and they have sudden onset of numbness, tingling in their arm and leg on one side, also associated with weakness on that same side. And if it's on the dominant hemisphere, which is your left hemisphere for most of us, then you'll end up with a slurred speech, or you have an inability to communicate. And so that's the kind of constellation of symptoms that you get with an embolic stroke.
Is that all immediate?
Oh, it happens just like that. Yep. It's like life. You're normal one day, and like that, you're gone. Yeah. So anyway, that's the embolic stroke. Now you can also get, like I showed you just a minute ago, you get this hemorrhagic stroke. Now you can have a hemorrhage from an aneurysm, which is in this upper diagram. So this is kind of what you get from an aneurysm. And this is what happens if you get a lenticulostriate hemorrhage into the basal ganglia. Okay. Now, hemorrhagic stroke is actually even more deadly, has a higher mortality and morbidity than a ischemic stroke. Most people actually survive an ischemic stroke. Have y'all ever known somebody had a stroke?
Mm-hmm.
Who had a stroke?
Oh, my best friend's dad had one.
Best friend's dad?
Yeah, we were younger.
Yeah.
So he was probably his early 50s.
Early 50s. So it can happen at any age. It's more common as you get older. And how about you?
My neighbor.
Neighbor? And what, do you remember what happened?
No, it was when I was young, but she was like, I
Older.
think she was like in her 70s.
70s, okay. And so, did they both live?
Yeah.
Okay, so you survived. Well, what happens after you've had the stroke?
My mom's friend, she lost function of her right arm, and
Yeah.
then she had put us for a little bit.
But you can get better, right?
Yeah, she got better.
So typically, they can go through rehabilitation. And it's not going to be the same, but you can kind of get better typically. Now that's not true for the hemorrhagic stroke. Hemorrhagic stroke almost always kills you. Okay, but the symptoms of the hemorrhagic stroke are the same. They produce, the same kinds of symptoms. You have weakness, paresthesias, you may have slurred speech if it's in the dominant hemisphere. So, as the emergency room physician step in, you got this patient who comes in with weakness, paresthesias, slurred speech. What are you going to do? So we have these. No, don't call me. We have these blood clot busters. TPA, y'all heard of tissue plasminogen activator, TPA. That's the clot buster medicine. So if we have somebody that comes in with a stroke within 3 hours, we can give them TPA, and they just miraculously, the clot goes away, and they just really recover quickly. What happens if we give TPA to somebody that has a lenticulostriate hemorrhage? Yeah, we'll kill them. That's right. Just like that, they just croak on you. So that's not a good thing. So how do we tell what kind of a stroke that they had? As an emergency room physician, you got to make these split-second decisions.
How long does it take to make an angiography?
Angiography?
Yeah.
Well, angiography, you have to call the neurosurgeon. He's probably out partying, he's half drunk, he doesn't want to train you. But you're the emergency room physician. So Andreas, what are you going to do? How about some kind of imaging, maybe? Our biomedical, our BME colleagues like to do imaging, right? So what is every emergency room? Every class 1 emergency room has a CT scanner. You can tell with the CT scanner real quick. CT will show you if you've got a hemorrhagic stroke. It actually shows the hemorrhage really quick. MRI is even better if you want to. You can do a MRI angiography even if you wanted to, but MRI is not 100% available, but almost any emergency room is going to have a CT scanner. You scan them, and you can see if somebody has a hemorrhagic stroke. Not only will you be able to see the hemorrhage inside the brain, but it'll also give you a midline shift. And so, just like we talked about, I guess when we were talking about some of the other issues with the brain and having pressure effects. If you get a blood clot in the brain, it's going to push everything to the other side. And so you can see where the clot is, and you see the midline shift. And in that case, you're really, really dealing with a really emergency situation. You go straight to the NICU, you get your neurosurgeon in, and he has to evaluate to see if you can possibly maybe evacuate that clot. So, I mean, your diagnostics have to be done very quickly. And it has to be done for the embolic kind of stroke. You have to begin the TPA within about 3 hours for it to be effective. Okay? So, intracranial aneurysm. Have y'all known anybody that had an aneurysm? So we have roughly 100 people in the room. Well, about 4 of us, I don't know who, maybe me. 4 of us have an aneurysm. It's pretty significant. It's in the United States, 6 million Americans have an aneurysm. So aneurysms are common. They don't usually bleed. They only rupture about 30,000 per year. But if they do rupture, then you got a 50% chance of dying. So of the 30,000 that rupture, about 15,000 people just die like that. And these are young, healthy folks, usually between 30 and 60, y'all's age, and the only presenting symptom is just a headache. So the next time you have a headache, just kind of remember this little fact. And so this is what an aneurysm looks like. So basically you have this blood vessel, and it does like this, and you get this bulging out. Now the most common place for aneurysm is in the junction between the posterior communicating and the basilar artery, or between the anterior communicating and the anterior cerebral artery. So it's at the junction between those really thin vessels in the circle of Willis and the bigger blood vessels. And so the symptoms, of a ruptured aneurysm are you get a really stiff neck. Okay, so you have a really bad headache, and a lot of times you get these little, minuscule little subarachnoid bleeds. So a lot of people that have aneurysm, if you go back and you look, they have had some symptoms that really they should have picked up on. But you have a really bad headache, and just afterwards just don't really feel quite right, and maybe your neck's just a little stiff, but you recover. The next time if it hemorrhages, it might be a big hemorrhage, and you might die very, very quickly. If it's a big hemorrhage, you get a big subarachnoid bleed. It'll compress the brain. Kind of like the picture there, where it shows the aneurysm, and you can get midline shift and press on the medulla and quit breathing. And so this is a really, really bad problem, because these are healthy people. These are all folks just like you that just all of a sudden have a really bad headache and bleed inside the head and die. Now it's treatable. Okay, how are you going to treat an aneurysm if you detect that you've got it?
Drain out the blood that's in your brain.
How?
Like drain out the blood.
Yeah, you don't have to do that. Okay, you don't actually have to do that. Yes.
Can you clamp off the aneurysm?
Yeah, you clamp it. And so every neurosurgeon has a little bag that has these Dandy Walker clips. They're little, they look like paper clips. And you basically just have to get access to the aneurysm, and you put a little clip right here across the neck, and the blood that's in that will eventually reabsorb, and it'll kind of go away. But you have to clip it so that it doesn't bleed. And so that's just one of the more common things that neurosurgeons do, is to clip aneurysms. Yeah. If the sac bursts after you click it, after you've done the clip, it doesn't make any difference, because the clip, see, is already cut off the blood supply. Once you clip it, well, I mean, if you do a good clip, nothing's going to come out, right?
You've already had a few.
Well, there's blood in the sac, but the body over months will reabsorb that. Once you cut off the access to the pressure, the blood, it'll go away. Yeah.
So does that clip just stay there permanently?
Yeah, it stays there. Yeah, you can't do an MRI scan. Right.
They have to use a metallic clip.
They typically do. Yeah. That'd actually be a good biomaterials problem. Maybe somebody do a project in this class on new materials for clips. Yeah.
What do you call that? Just aneurysm?
An aneurysm clip. Yeah, I think Dandy Walker clips. That's kind of the name I remember. Okay. Any other questions? So let's look now at some of the other features of anatomy. And so when you kind of look at the brain, you kind of see how it plugs into the skull that I showed you the last time. You've got this anterior cranial fossa for the frontal lobe. You got the middle cranial fossa for the temporal lobes, and you got the posterior cranial fossa for the cerebellum. And then the deeper part of the brain, which you have to peel the cortex off, is called the insula of Ryle. This is the old part of the brain. Actually, it's really important in olfaction and memory. And we'll see that on some other cross sections. But this part right here, the insula of Ryle, includes the older structures like the uncus, the hippocampus, and some of the structures that are very important in memory. The sulci they're pretty much self-explanatory. I mean, you've basically got superior temporal gyrus, you've got the pre and post central gyri, you have the occipital, the calcarine fissure, calcarine cortex, and then but really that's not hard. Anyway, so this is a sagittal section through the brain, and this actually has some very, very important things that we do have to learn in this class, and we're going to be talking about that have a lot to do with the wiring diagram for the brain. So let's start with the kind of the easy part here. So we have the cerebellum here. So we have the brainstem, the medulla, the pons, and then this little part right here, which is the mesencephalon. And the mesencephalon is divided into two major kinds of pieces here. One is called the cerebral peduncle, which are the white matter tracts that are coming in and out of the brain. And then on the back side is the quadrigeminal plate, or the corpus quadrigemina. But basically it's we have the superior and inferior colliculi. Anyway, then we have the pineal gland here. This structure right here is the posterior commissure, anterior commissure. This big structure here is the big white matter tract that connects the right and left brain, the corpus callosum. We have the fornix here. This is the fornix, comes right here. The fornix is a very important tract for memory. It connects the mammillary bodies to the hippocampus. Okay. All of this area right here is the third ventricle and the thalamus. Here's the aqueductus sylvius here. Here's the optic chiasm, here's the optic recess, and that's the hypothalamus. So you can kind of see how, this area right here is all thalamus. Okay, here is the mammillary body. You can kind of see how this tract, the fornix, comes over to the uncus in the part of the hippocampus. Give you an idea, again, kind of the relationship between kind of these major structures here. This horizontal section, which shows things in a little different perspective. So here, instead of cutting this direction, we've cut like this, and you see a very, very big white matter tract, which is called the internal capsule. Okay, this is the white matter tract that has fibers that come from below coming up and from up coming down. So the big white matter tract corpus callosum goes right left. Internal capsule goes up and down. Okay, so this is the big connection. It turns out that one little tiny part of that is very, very important for our motor function. The most anterior part of the posterior limb of the internal capsule is where all your motor goes. This is all your motor function. Now I'm going to teach you a trick here, okay? Because when we start looking at just the real dissections, it's really hard sometimes to tell where you are and what you're looking at. But I'm going to teach you a trick. Anytime you see the third ventricle, think thalamus, okay? Anytime you see third ventricle, first thing that comes to your mind is thalamus. So here we have third ventricle, and all of this here and all of this over here is the thalamus. The thalamus is medial to the internal capsule. So that puts you into kind of a perspective. Now if we go lateral to the internal capsule, we see the lentiform nuclei, these structures over here, which are those diencephalic structures which are important for program memory. And so these structures taken together is called the globus pallidus. The Gesundheit, putamen, and the caudate nucleus. And so these three structures we kind of think of together. Now it turns out that the caudate is also like the thalamus medial to the internal capsule, but it's only in the anterior-most sections, and it's not where you have third ventricle. So when we look at other cross sections, that's a good way to kind of differentiate that. And so all of these taken together, we basically call this the basal ganglia. So basal ganglia are those three things, the globus pallidus, putamen, and caudate. And so, depending upon where you look at the cross-section, you may or may not see all or complete structures there. This is a picture looking down on the brain, and again, I'll point out to you that whenever you see the third ventricle, then all of this is going to be thalamus. Okay, we're actually now looking at the dorsal aspect of the brain. This is the quadrigeminal plate. That's the superior and inferior colliculi. You also can see the pineal gland, which is right here. So that kind of puts that into some perspective. Turns out that the thalamus is the great relay nucleus of the brain. So all your sensory information, including vision, everything, the only exception is olfaction. Everything except olfaction actually goes through the thalamus. So even vision, the lateral geniculate nucleus is actually a part of the thalamus. So all of your proprioception, pain and temperature, all of that is going to go actually to this particular part of your thalamus right here, which is called the ventral posterior lateral nucleus of the thalamus. Okay, so now this picture is looking like we have removed part of the cerebellum. And so again, we're looking down actually into the fourth ventricle, and we're looking down on the brainstem from the dorsal aspect. And so you can see the quadrigeminal plate, the superior and inferior colliculi. The superior colliculus is vision. Inferior colliculus is hearing. These are relay nuclei. So they're on the quadrigeminal plate, which is just behind the aqueduct. You can kind of see that here. So here's the quadrigeminal plate. That's exactly what you're looking at right there. Here's the aqueduct. Okay, the white matter tract. So another thing that's important to catch real quick here is the internal capsule turns into the cerebral peduncle. So as the internal capsule, remember it kind of looks like this when we looked in cross section. As those fibers go down, so the internal capsule turns into the cerebral peduncle as it gets into the mesencephalon. So all these fibers, all these motor fibers that make for all of our movement are actually getting very, very compressed in a very small area in the mesencephalon, in the cerebral peduncle. It's a place where you can get lacunar infarct. A lot of times diabetics will actually stroke out in the cerebral peduncle as opposed to up in the brain. One other thing that's very difficult probably to comprehend without actually seeing me actually do a real live dissection here is that the cerebellum is held on to the brainstem by really only three little tracts. So basically there's just like these three little fascicles that connect the cerebellum to the pons. Okay, and so these little fascicles, are called the superior, middle, and inferior cerebellar peduncles. Three of them. They're also called brachium conjunctiva, brachium pontis, and the restiform body. You'll see that in the literature too. Superior, middle, and inferior cerebellar peduncle, brachium conjunctivum, the restiform body, and the cerebral peduncle. So basically, those are the important ones that kind of hold the cerebellum on. If we remove that, we can then, like I said, look down on the fourth ventricle, because fourth ventricle is where the cerebellum is, and you can visualize some of the nuclei or the areas where the nuclei for these cranial nerves that we're going to look at in just a second. Okay, so this is out of one of the dissection manuals that we use in the graduate class, and I'll point out to you that these are all negative images. So wherever the white matter tracts are, they're black. I mean, it's really kind of confusing. So I hate to get you confused here, but basically everything here is just kind of the opposite of what it really does look like. But just understand that. But these are good pictures, and they have the names that are important for this class. And so here we can see we can see the cerebellum. Here's the fourth ventricle here. Third ventricle would be up here. So this is all thalamus right here. This is hypothalamus, and the hypothalamus is very intimately related to the optic chiasm. So whenever we think of diseases or the relationship between hypothalamus, it's a lot of times we end up with syndromes that actually affect vision because of the optic chiasm. So basically, you know, here's your optic nerve here, and this is the hypothalamus. Here's your thalamus. This is the fornix. You have to remember, you know, that the fornix is connected to the hippocampus connected to the thalamus. You know, you have to kind of go through all this stuff. You have to kind of see how they're kind of related here together. Make up your own little song. This is the cingulate gyrus here. That's important in memory. Here's the corpus callosum here. And so what I'm going to do here is, so the way we actually dissect to study the brain is we put the brain in like a little bread box, and we have a knife and we just start slicing it. And so this is, I'm going to start slicing it here, here, here. We're going to start anteriorly, and we're going to kind of work in this direction. Okay, and when I do that, if I'm very, very far anterior, I'm way in front of the third ventricle. So all I have here are the lateral ventricles. Here's the lateral ventricle, lateral ventricle. This structure here is called the septum pellucidum. But at this point, I have just a little tiny bit of the internal capsule. Okay, but I've got a big nucleus here. This is the head of the caudate right here. Okay, and so you can see a little bit of the putamen, but this is all caudate. Here's the corpus callosum. That's the other structure. It's important on that slide. If we go back, now this is the next section as we go more posteriorly. We still have the lateral ventricles here. This is the caudate. Here's that big white matter tract that's going down. This is the internal capsule. Here's the globus pallidus. Here's the putamen. Here's the optic chiasm. Okay, those are the kind of important things on that slide. This is the anterior commissure. This area underneath the anterior commissure is all hypothalamus. This is the optic recess because here's the chiasm right here. Okay, this is lateral ventricle, lateral ventricle. This is the fornix, internal capsule, caudate, globus pallidus, and this is the putamen. Okay, it's not rocket science. Anyway, here we go down. Here's the third ventricle. When you think of third ventricle, what do you think about? Thalamus. Okay, so you know you got thalamus. Okay, here's thalamus. Here's the internal capsule. Here are those other nuclei that we've been talking about in the lentiform nuclei. Still got the fornix, still got the septum pellucidum, still a little bit of the lateral ventricles here. Now we're back far enough to where we have the optic tract. We're behind the chiasm, and then we have the optic recess. So basically this area right in here is going to be hypothalamus. Going back a little bit more, and we keep going back a little farther. Again, you know, here's the third ventricle here. All of this is thalamus, internal capsule, lentiform nuclei. Here's the choroidal plexus and the lateral ventricles, corpus callosum. Beginning to see a little bit of the older part of the brain in the temporal lobe, the amygdaloid nucleus and hippocampus. So as we kind of follow this back a little bit further, it turns out that the amygdaloid nucleus is where you have a lot of your emotions. So anger, love, hate, you know, kind of expressed in this particular part of your brain, old part of your brain. Very, and actually it's different. The cortex, your cerebral cortex, has typically, you know, if you look at it, it's got 6 layers of cells. This only has 3. It's very old. It's connected to your olfactory system. Now we're picking up something really kind of cool. These are the mammillary bodies. To get back to this circuit, you know, you basically have the mammillary bodies, fornix, uncus, amygdala, hippocampus, anterior thalamic nucleus, cingulate gyrus. That forms the great memory circuit of Papez, or the limbal circuit of Papez. And we'll study that in much more detail as we go along. But we have here kind of the thalamic nuclei, the ventral lateral nucleus here. We have just a little tiny bit of the caudate on this slide. Big picture here of the fornix. internal capsule. You can see how the internal capsule is kind of projecting down into the brainstem. And this is a very, very big white matter tract that's going motor and sensory from the brain down into your spinal cord. Okay, a little bit further down, you can see how the internal capsule now is connecting with the crus cerebri. We're down into the area of the mesencephalon. All of this is thalamus now. Is the hippocampus. We're third ventricle here. We can see some of the really more important, the lateral VPL. All of this is VPL. We'll be studying this. You'll understand VPL really good after we get through the next few lectures. But basically, this is a huge relay nucleus for sensory information. This is concerned with the cerebellum. See the fornix here. And we're picking up two new structures here. One is the red nucleus, okay? The second is the subthalamic nucleus, and the third one is the substantia nigra. Now, it turns out that these are the oldest nuclei in the diencephalon. So you can kind of think of the red nucleus, the subthalamic nucleus, together with the substantia nigra in terms of being able to regulate rigidity and repetitive motion. So it turns out that that's kind of what that part of your brainstem does. Now you can see it a little bit better here. Here is the red nucleus, and actually on a fresh brain, when you look at it, it actually does look red, okay? The substantia nigra looks black. That's how it got its name. And then you've got the subthalamic nucleus here somewhere, right here. Those are the old structures. Here's third ventricle, and then here are these are all other thalamic nuclei. Fornix is here, corpus callosum, lateral ventricles, and so on. And then as we get further down, you're beginning to see now not mesencephalon, but you're beginning to see the pons. Here is the crus cerebri. That's where the internal capsule's gone. We have the temporal lobe here. This is the hippocampus, and you can see the substantia nigra and the subthalamic nucleus. So you kind of get that structure as we go down. You kind of see how they progress as we. And this is even bigger. So now we're now down into the pons, and we have the brachium conjunctivum, superior cerebellar peduncle there, and I think we're still above the middle, or maybe the middle cerebral peduncle here somewhere. This is how big the aqueduct of Sylvius is. See how little? Remember we talked about that's a place where it can get obstructed very easily? Very, very small. All that fluid has to go through there. This is the pulvinar part of the thalamus here. A little bit of the fornix. Still see it a little bit there. Okay. So anyway, those are the structures. You don't have to know everything, but just those are the structures you need to learn for this class, because we're going to talk about how they get involved in the wiring diagram. Okay? Now, any questions on that before we go to the cranial nerves? Okay. We have 12 cranial nerves. It's again not rocket science. Information gets to our brain and from and to, in and out, afferent, efferent. There's only 13 ways it can get in and out. One is the spinal cord, the other is the 12 cranial nerves, okay? And so you need to learn the name, function, and structure of all the cranial nerves and where they exit, if they do exit, from the intracranial space. First cranial nerve is the olfactory nerve. Olfactory nerve is the nerve of smell. We talked about, the olfactory bulb sits over the kind of the upper part of the cribriform plate. Remember we looked at that on the skull. And actually it does not ever leave the intracranial space. And that's the nerve of olfaction, our oldest sense. And as we'll see as we go through this class, olfaction is very intimately tied into memory. And your very, very strongest memories have either some association with olfaction, or they have a lot of emotional character to them. So you have a lot of your very deepest memories, the ones that really that last you a lifetime, are those that carry a lot of emotional baggage along with it. Second cranial nerve is the optic nerve. The optic nerve leaves the intracranial space through the optic canal. It's the nerve of vision. The optic nerve has about 1 million asynchronously firing neurons. It's the biggest of all the cranial nerves. The optic nerve is kind of unique in that the optic nerve, here's the two eyeballs. Basically, the nasal fibers cross over, and so I should have done this different so you can tell. Okay. And so it turns out that the nasal fibers from both eyes cross over in the optic chiasm. So when you get back to the lateral geniculate nucleus right here, basically you're looking at this part of the retina in one eye and this part in the other, which are looking at the opposite visual field. So your left, well, let me back up. So this would be your right. Let's look at this as being the right. This is your right visual field. See, because the nasal fibers crossed over, is going to project to the left part of your brain. Everything in your right visual field goes to the left brain. Everything in your left visual field goes to your right brain. Because of the optic chiasm, it crosses over. Okay? Now, I just went through some pictures and showed you, hopefully convinced you that your optic nerve is very, very closely related to your pituitary gland. Pituitary gland is a place where you can very commonly get an adenoma or a tumor. Okay? And if that happens, you cut the optic chiasm. You basically just physically cut it. And if I have a pituitary adenoma that's affecting the optic chiasm, what kind of visual field defect do I have? Do what?
Loss of peripheral vision to one side.
Just one side?
Well,
I
like
cut the
that.
chiasm.
Like you won't be able to see on the left side.
If I cut the chiasm, I will have a bitemporal hemianopia. I lose my temporal visual field in both eyes. Can't see to either side, way out to the side, because I've cut the nasal fibers from either eye. End up with a bitemporal hemianopia. Okay, good thing to remember. That's a clue to a lot of different diseases. Chiasm, bitemporal hemianopia. What happens if I cut back here in the optic radiation? What do I end up with?
Loss of vision.
I can't see anything to that other side. Okay? That's called a homonymous contralateral hemianopia. Homonymous contralateral hemianopia. If I cut the radiations on the left side, I can't see anything to the right in either eye. Okay? So you can see how by me being able to study your visual field, I can tell where your pathology is in your head. Y'all see how I'm doing that? Okay? So I can very quickly, if you come in with a visual field cut, I can do some tests real quick and I can pinpoint exactly where your tumor is, where your pathology is. Isn't that cool? Okay, power of knowledge, right? Any questions about, we're going to study this. If you think you get rid of me this semester, you're not right, because I come back and we're going to have another really long, in-depth kind of picture of how this works in the spring semester. So you'll get another dose of this anyway. So that's the second nerve. Okay. Third nerve, fourth nerve, and sixth nerve we think of together. They're all the nerves that go to the extraocular muscles. So the oculomotor, the trochlear nerve, and the abducens nerve, 3, 4, and 6 we think of together because they all go to the extraocular muscles. Okay. Now, I'm gonna show you something here, which this is a real gem, okay? Because if you remember this, you really do understand, you know, what's going on here. And so the third cranial nerve. So the way I like to do this is like this. I just make two X's, okay? Like this. So this is the right and the left, okay? And so we have, we really only have a few extraocular muscles that move our eyes. And so we can pinpoint the pathology in the third, fourth, and sixth cranial nerve just by using a pen light and just looking at your eyes. And so the muscle that moves both eyes in is called the medial rectus muscle, okay? The inferior oblique rotates the eye up when you're adducted, okay, adducted. Superior rectus, this will be the lateral rectus. Superior rectus, and inferior rectus. Okay. Now it turns out that the fourth nerve, this is the fourth nerve, is going to go to the superior oblique muscle. That's the only thing that does. The lateral rectus is innervated by the sixth cranial nerve. Okay. And all of the other muscles, the medial rectus, superior rectus, inferior rectus, they're all innervated by the third nerve. So if I don't have anything on the diagram, everything else is the third cranial nerve. So if I have somebody and I just have them look to the right and left, which cranial nerve is not working? Where's Elizabeth? Pick on you. Haven't picked on you for a while. Which cranial nerve is out? This person has a paralysis of the something cranial nerve.
Why are there 3 pairs of eyes?
Well, because you have 2 eyes. So this is how the patient looks. You have them look to the right. So you look over to the right. You look straight ahead. Then you look to the left. And ordinarily, the 2 eyes should just track right along. So what do you think, which one is not working? What doesn't look right?
The left.
So something over here with the left eye, right? This is right eye. This is O-D-O-S. Okay, something is wrong here with the left eye. It's not turning out. It should have gone out. So go back and look at my diagram. Which muscle's not working? The lateral rectus. This one's not working, right? So which cranial nerve's out? Sixth cranial nerve on the left side. You've got a sixth cranial nerve palsy. Okay? Now see how smart you become. Now you can diagnose. You can, and you just remember that diagram, memorize that diagram, you can tell just by using a pen light which cranial nerves work and which cranial nerves do not work. Okay? All right, that covers the cranial nerves through. Oh, I must mention, the third cranial nerve also, it constricts the pupil. Right? So remember we talked about the third cranial nerve. It's also got the parasympathetic fibers that release acetylcholine that constrict the pupil. So it has, in addition to the extraocular motor function, it is responsible for constricting. Okay, any questions about that? So I should be able to draw a picture of something like that, and then you're going to tell me which cranial nerve is not working. So you might practice, and this is a real gem. If you just memorize this, it absolutely will make it super easy for you to figure out which cranial nerves work and which ones don't. Okay? Any questions about 3, 4, and 6? Okay. Yes?
How do they lose their cranial space?
Okay, that's a good question. Where did 3, 4, and 6? They all go the same place. We talked about that. 3, 4, and 6 leave the intracranial space through the superior what? Orbital fissure, SOF, superior orbital fissure. They're all kind of together. As a matter of fact, 3, 4, and 6 are actually traveling. They actually go through the cavernous sinus, and so they're actually traveling through the same structure that the carotid artery goes through too. And so it's not uncommon with, for example, the carotid cavernous sinus fissure that we talked about, because now you've got all that pressure, you'll knock out some of the cranial nerves. You may knock out part of 3, 4, or 6, because they're actually going through the cavernous sinus too before they go to the superior orbital fissure. Okay? Does that answer the question? Okay, fifth cranial nerve is the trigeminal. Trigeminal, 3 big ganglia, trigeminal nerve. This is an easy one to remember because the trigeminal nerve has 3 branches. It has an ophthalmic, a maxillary, and a mandibular branch. We also call them V1, V2, and V3. So trigeminal, it has an ophthalmic or branch that goes to the forehead and the eye. It has a maxillary, goes to the maxillary part of your face, and it has a branch that goes to your mandible. It's responsible for only 2 things. It's responsible for sensory information. It basically gives you the sensation on your head, okay? So if you have a contact lens problem and your eye hurts, that is the first division of the 5th cranial nerve, which is signaling that you have a problem, okay? If you go in and see your dentist and you have a bad tooth on the upper part of your mouth, the dentist will probably anesthetize the maxillary branch in order for you to not have pain when he goes in and starts drilling on your tooth or pulling your tooth or whatever. Okay? And the second division of the maxillary, actually you can feel it on your own eye. If you just feel your orbit, okay, feel right where the bone is there. There's a little notch. Can y'all feel that? Feel that? That's where the maxillary nerve leaves the eye, and then it goes down over your maxilla. So the dentist, all he has to do is give you a little injection somewhere right there, and it'll go to sleep. Okay? And the mandibular branch then goes to the teeth that are on the lower part of your mouth. You feel the little notch there? There's a little groove. If you feel just on the inside, there's like a little tiny groove there. Okay, and that's where the maxillary division of the trigeminal nerve leaves the orbit. Okay, we're out of time. Any questions? We'll start from here next time.
Where does 5 leave?
5?
Yeah, where does
3 places. First
Oh,
Division,
okay.
Superior Arbor Fisher, Foramen Rotundum, and Foramen Ovale.
Do we have to know those?